So we begin with our subject-wise test of pediatrics from question number 36 to question number 70. And question number 36 was, a previously well child was admitted in the pediatric ward with complaints of yellowness of eyes and increased yellowness of urine. His liver function tests revealed raised serum bilirubin with raised hepatic enzymes. He is admitted in the pediatric ward and is monitored for oral acceptance and bleeding. On day 3rd of admission, the mother complains that the child is now sleeping in the day and is awake at night. On examination, he is found to have slight asterixis. What is your impression of this? And the correct answer to this question is option number B, that is, the child has now progressed to stage 1 of hepatic encephalopathy. So question number 36, the correct option is option number B, that the child has progressed to hepatic encephalopathy stage 1. So there are different stages of hepatic encephalopathy that you should know. Depending upon the clinical features and the signs, the hepatic encephalopathy can be classified as, in stage 1, the child there is usually inconsolable crying, there is inattention to task, and there is altered sleep-wake cycle. So, like in this case, the clue was that the mother was saying that the child is sleeping in the day and is awake at night. So, altered sleep-wake cycle. And amongst this sign, usually the child is normal or hyperreflexic, and asterix is usually absent or is slightly elicited. In stage 2, the clinical features would be same as in stage 1, but in the signs, the child may be normal or hyperreflexic, but asterix is easily elicited. So the clue here was between 1 and 2, it was because there was slight asterixis, that's why we had said that the child has progressed to stage 1. While in stage 3, there is extreme somnolence or stupor, and child is hyperreflexive, and asterixis is present. While in stage 4, the child is comatose. If responsive to pain, classified as 4A, and if not responsive to pain, classified as 4B. While in signs, they may be decerebrate or decorticate posturing. And by this time, asterixis has disappeared. So this is how we stage hepatic encephalopathy. So now we come on to question number 37. And question number 37 is, all are features of hyperthyroidism except. And the correct answer to this question is option number D, that is menorrhagia. In hyperthyroidism, the complaint is of oligomenorrhea and not menorrhagia. So this is the correct answer to these questions. So what are the clinical features of hyperthyroidism? There is tachycardia, there is weight loss, there is heat intolerance, the skin is warm and moist, there may be muscle weakness, occasionally or rarely there may be psychosis, there may be pruritus, there may be increased stool frequency, and there may be oligomenorrhea in case of hyperthyroidism. So next we come on to question number 38. And question number 38 is, the most helpful diagnostic test in the case of a solitary nodule is, and the correct answer to this question is option number B, that is FNSE. So what are the investigations that can be done in case of a solitary nodule? Well, you can get an ultrasound done, which is also one of the options given in this question. But the ultrasound will tell you whether the nodule is either solid or cystic. And it will also identify some non-palpable nodules. You can also get a thyroid scan. But the thyroid scan will also tell you whether the nodule is cold, warm or hot. But it is only the FNSE which will give you a tissue diagnosis telling you whether it is a benign lesion or a malignant lesion. So that is why the correct answer to this question is option number B, that is FNSE. Now the next question is question number 39, which says multiple endocrine neoplasia or MEN2A includes all of the following except, and the correct answer is option number B, that is papillary carcinoma of thyroid. So question number 39, the correct answer is option number B, that is papillary carcinoma of thyroid. So MEN2A is a group of disorders which is associated with tumors of the endocrine system. So MEN can be 2A and 2B. In MEN2A, it is characterized by pheochromocytoma and parathyroid hyperplasia. And if it has all types of MEN2 will have pheochromocytoma and medullary carcinoma of thyroid. While if there is presence of parathyroid hyperplasia along with pheochromocytoma and medullary carcinoma of thyroid, it is classified as MEN2A, and if there is mucocutaneous neuroma or GI symptoms along with pheochromocytoma and medullary carcinoma of thyroid, it is classified as MEN2B. So this is the difference between MEN2A and MEN2B. So next we come on to question number 40, and question number 40 was Digeorge syndrome includes all of the following except, and the correct answer is option number D, that is neonatal hyperglycemia. So the important components of Digeorge are neonatal hypocalcemia, conotruncal defects of heart, and velopharyngeal insufficiency. So few salient points about Digeorge syndrome. Well, Digeorge syndrome results due to deletion of 22q11.2. It is characterized by aplasia of the parathyroid gland, resulting in neonatal hypocalcemia in almost 60% of patients. Along with that, there are conotruncal defects as well. There are velocardiopharyngeal insufficiency, and other associated abnormalities of the third and the fourth pharyngeal pouches. So you can also see cleft palate, renal anomalies, and even thymic hypoplasia, resulting in severe immunodeficiency. So these are the important components of Digeorge's syndrome. So next we come on to question number 41, and the question number 41 is, a 2-year-old boy came with complaints of gross hematuria. His mother gives a history of cough and cold since 2 to 3 days and no fever. What is the most probable diagnosis? And the correct answer is option number D, that is Iga nephropathy. So the clue here was that the child has developed hematuria just 2 days after his symptoms of cough and cold. So that's why we have opted for Iga nephropathy. So the clue here is that it was a short incubation period. While in hematuria, the most common cause of gross hematuria in children is PIGN, that is post-infectious glomerular nephritis. But in that case, hematuria will result 10 to 14 days after an upper respiratory tract infection or any skin infection. So here, because it has resulted after 2 to 3 days, we have opted for Iga nephropathy. Well, the clinical manifestations of Iga nephropathy are different in US and Europe and in Japan. In US and Europe, patients with Iga nephropathy may present with gross hematuria, while in Japan, they may present with either microscopic hematuria or with proteinuria. Apart from the shorter period, apart from that it appears earlier after a URI, another differentiating feature from PIGN is that C3 levels are normal in case of Iga nephropathy. C3 levels are normal. And further, serum IgA levels are of no use in diagnosis as they are elevated in only 15% of patients. So next we come on to question number 42. And question number 42 was again about Iga nephropathy, and the question was, the primary treatment of Iga nephropathy is And the correct answer is ACE inhibitors. So why we have opted for this answer is because the primary pathophysiology that results in IgA nephropathy is proteinuria, which causes renal damage. So our primary treatment is towards reducing this proteinuria, which is possible with ACE inhibitors. In severe cases, immunosuppression by using corticosteroids or other forms like other drugs like cyclophosphamide and cyclosporine may also be taken up, but the primary treatment modality is reducing proteinuria, and for that we need ACE inhibitors. So that is why the correct answer to this question is ACE inhibitors. Next we come on to question number 43. And question number 43 was, confirmation of diagnosis of post-streptococcal glomerulonephritis is done by, and the correct answer is option number C, that is streptozyme test. Option number C, streptozyme test. Well, why is the answer to this question streptozyme test? Is because to diagnose post-streptococcal glomerulonephritis, we need evidence of preceding streptococcal infection. So anti-streptolysin O and other enzymes may not be elevated in all patients. And so why we have opted for this is because streptozyme test will detect 5 different enzymes against 5 different antigens of streptococcus. So it will detect 5 different enzymes in a single test. So it will test against streptolysin O, it will test against deoxyribonuclease, it will test against hyaluronidase, it will test against streptokinase, and also against nicotinamide, adenine dinucleotidase. So not just by estimating a single enzyme, by doing a streptozyme test, we will assess 5 different antibodies, 5 different antibodies, and hence this would be a preferred test to look for evidence of preceding streptococcal infection. So next we come on to question number 44. And question number 44 is, identify the correct statement. And the correct option is option number C, that is Bellog-Taussig shunt occurs between the subclavian artery and the pulmonary artery. So the correct answer to question number 44 is option number C. Now what are these shunts, various shunts that have been shown in this question? So you see there is a Waterson's shunt, there is a Potts shunt, and there is a Bellog-Taussig or a BT shunt. All these shunts are used in the palliative treatment of patients with TOF physiology. So the BT shunt is between the subclavian artery and the pulmonary artery. While the Potts shunt is between the descending aorta and pulmonary artery, and the Waterson's is between the ascending aorta and the pulmonary artery. So these are the 3 shunts that are used in palliative surgery for patients with TOF physiology. Hence the correct answer was option number C, that is BT shunt is between subclavian artery and pulmonary artery. So next we come on to question number 45, and question number 45 is, a child presents with developmental evaluation. When his language milestones are assessed, he is seen to speak 10 to 15 words. The most likely age of the child is, and the correct answer is the correct option is 15 months. That is option number B. (15 months). So if we see the vocalization in a child, the child will start cooing by around 3 months of age, and he will start babbling by around 6 months of age. The child will say the first word with meaning by the time the child is around 10 months of age. And a child, by the time he is 15 months, he will be able to speak 10 to 15 words with meaning. And by the time the child is almost 2 years, he will have a vocabulary of almost 100 words, 100 meaningful words. The vocabulary will comprise of 100 meaningful words by the time the child is around 2 years of age. So next we come on to question number 46. Question number 46 is, injectable polio is now a part of the national schedule. Its recommended primary dose schedule is, and the correct option is option number C, that is 6 and 14 weeks. So as a part of the endgame strategy in polio eradication, now in the national schedule, injectable polio vaccine is being administered at 6 and 14 weeks along with pentavalent vaccine. But this vaccine that is being administered in national schedule is a fractionated dose, which is given through the intradermal route. However, the IPV can also be administered through the intramuscular route, in which case the best schedule is to be given in an interval of 4 weeks in 3 doses. But if the interval is increased to 8 weeks, even a 2-dose schedule would work. So 2 doses can also be given if 8 weeks interval is kept between these 2 vaccines. But at present, in the national schedule that we are following presently in our country, we are using a fractionated dose which is given by an intradermal route at 6 to 14 weeks of interval. So next we come on to question number 47. Question number 47 was, 2 live vaccines can be administered on the same day but at different sites. However, which of the following 2 live vaccines cannot be given on the same day? And the correct answer is option number A, that is BCG and measles. So we should know that when we are administering 2 vaccines, we either administer them at a single sitting. If it is not possible and if the child has to be called for another vaccination, it is preferred to keep a 4 weeks interval. This is to avoid any interference of the interference within the body by one of the vaccines. It should not happen that one vaccine inhibits the generation of antibodies by the other vaccine. So that is why we prefer to keep a 4 weeks interval. But BCG and measles are two vaccines which, both being live, cannot be given even in a single setting. So if a child is coming to you at around 10 months who is unimmunized, you should not give him BCG and measles together. So next we come on to question number 48. Question number 48 is, a 4-year-old child comes to you with a history of dog bite from a street dog. This child had already received BCG vaccine last year, full course. What will be your next course of action? So the correct answer to this question is option number C, that is booster doses at day 0 and day 3. So 2 booster doses at day 3, day 0 and day 3. So there is slight controversy with regard to rabies immunization in a child who has already taken a full course of immunization. So some textbooks mention that irrespective of the duration of the previous vaccination, if a child has been bitten by a dog later, he needs only 2 doses at day 0 and day 3. But in some textbooks mention that if it has been less than 5 years, then only 2 doses need to be given at day 0 and day 3. However, if more than 5 years have elapsed to the last vaccination of rabies that the child received, then the entire course has to be repeated. So in this question, if you see, it was mentioned clearly that the child had received rabies vaccine last year. So in this question there was no confusion, and hence the answer was question number C, that this child will receive 2 booster doses at day 0 and day 3. So next we come on to question number 49. And question number 49 was, which of the following conditions is associated with cholestasis and butterfly-shaped vertebra? And the correct answer to this question is Alagille syndrome, option number B. So Alagille syndrome is associated with cholestasis and butterfly-shaped vertebra. So we see that Alagille syndrome is a autosomal dominant genetic disorder that mainly affects liver, kidneys, skeletal system and few other systems of the body, including the eyes. And it has been seen that within the same family, the symptoms may vary so much that some family members may have asymptomatic disease and some may have such severe disease that they may warrant either a renal or a liver transplantation. So in the liver, if you do a liver biopsy, you will see there is paucity of bile ducts. So in the liver, you may see paucity of bile ducts. In the heart, you may see pulmonary stenosis or condition like TOF physiology. In the eye, you may see pigmentary retinopathy. And posterior embryotoxon. And in the skeletal system, you may see butterfly-shaped vertebra. So these are the important features about Alagille syndrome. So next we come on to question number 50, and that is, a 12-month-old infant is unable to sit by herself and parents have noticed an exaggerated startle response. What are you most likely to find on physical examination? And the correct answer to this question is question number C. That is cherry red spots. So this condition which we are discussing in this question is of Tay-Sachs disease, which is a neurodegenerative disorder that results due to deficiency of hexoaminidase A. And why we are saying this is because the clue in this question was an exaggerated startle response, which is characteristically seen in Tay-Sachs disease. So children who have Tay-Sachs disease, they show progressive weakness and loss of previously attained milestones. Apart from that, they may also have seizures, blindness, which progresses to severe spasticity, and eventual total incapacitation, and death by almost 4 years of age. And it is important to know that there is no hepatosplenomegaly in case of Tay-Sachs disease. So these are few salient points about Tay-Sachs disease, that it is a NDD, it results due to deficiency of hexoaminidase A, there is an exaggerated startle response, and there is no hepatosplenomegaly in case of Tay-Sachs disease. So next we come on to question number 51, and question number 51 was, electrocardiogram of thiamine deficiency shows, and the correct option is option number B, increased QT interval and inverted T waves. The ECG findings in case of thiamine deficiency are increased QT interval and inverted T waves. Like we have already discussed in one of the previous questions on thiamine, that cardiac lesions are the most common cause of death in patients with thiamine deficiency or beriberi. Certain ECG characteristics are known to occur with thiamine deficiency, and they are shortening of PR interval, increased QT interval, inverted T waves, and low complexes, QRS complexes. So next we come on to question number 52, and question number 52 was, not true about paroxysmal hypercyanotic attacks is, and the correct answer is increase in intensity of the systolic murmur is usual. So we know about, so this question was about the hypercyanotic attacks. So the hypercyanotic attacks are also known as TET spells, and they are usually seen in children who have decreased pulmonary blood flow or in whose condition pulmonary stenosis is also a component. So patients who have TOF physiology are seen to have these spells, and they are common in children less than 2 years of age, and it commonly results whenever there is an infundibular spasm which results in the increasing severity of the pulmonary stenosis, which results in an increased right to left shunt. Which results in increasing deoxygenation of the blood and resulting hypoxia. The child is seen to be crying incessantly, and he is found to have deep and rapid breathing. With this, there is an increase intensity of cyanosis, and decrease in the intensity of the murmur. This spell or a hypercyanotic attack is an emergency. So emergency treatment is warranted. Usually it results in early morning or when the child is crying unconsolably. So this was about the hypercyanotic attacks. Next we come on to question number 53. And question number 53 is, a 1-day-old baby presents with excessive frothing, drooling of saliva from the mouth, and the baby was cyanosed. Which of these is the most likely cause? And the correct answer to this question is option number A, that is esophageal atresia. So you see the clues in this question were, there is excessive frothing. There is excessive frothing. There is drooling of saliva. And the child is just day 1 of life. So this is immediately at the time of birth. So there is excessive frothing, drooling, and the child is cyanosed. So probably if feeding has been tried, then the child will also become cyanosed. So this condition is seen in patients with esophageal atresia. It is often associated with a tracheal fistula as well. This condition can be suspected in case in an antenatal ultrasound there is evidence of maternal polyhydramnios. And if there has been a single umbilical artery. Often esophageal atresia and tracheoesophageal or tracheal fistula is associated with bacterial anomalies, whereby there are certain vertebral anomalies, anorectal malformations, cardiac malformation, tracheoesophageal fistula, renal anomalies, and limb anomalies. So once a diagnosis of tracheoesophageal fistula has been made, the child needs to be taken for surgery. So surgical repair is a definitive treatment, and in such children, feeding should not be initiated before the surgical repair is done, because there is a fistula. So if the feeding is initiated, it is likely to get aspirated and it may cause chemical pneumonitis in these children. Hence, before surgical feeding should not be initiated till surgical repair is undertaken. So next we come on to question number 54. And question number 54 was, the pathologic changes of Eisenmenger's syndrome of medial hypertrophy and intimal hyperplasia is classified under, and the correct answer is option number C, that is grade 2. So how do we grade Eisenmenger's syndrome? So in grade 1, their changes involve only there is only medial hypertrophy. While in grade 2, there is medial hypertrophy along with intimal hyperplasia. In grade 3, you see there is almost near obliteration of the vessel. In grade 4, it progresses sometimes to leading to arterial dilatation. And grade 5 and 6 will have vessel abnormalities in the form of plexiform lesions and angiomatoid formation and fibrinoid necrosis. And grade 4 to 6 indicate irreversible pulmonary vascular obstructive disease. So we see that in grade 1 there is just medial hypertrophy, while in grade 2 along with medial hypertrophy there is intimal hyperplasia as well. In grade 3 there is a near obliteration of the vessel lumen, and grade 4 leads to arterial dilatation, while in grade 5 to 6 there may be plexiform lesions, angiomatoid formation and fibrinoid necrosis, and grade 4 to 6 indicate that there is irreversible pulmonary vascular obstructive disease that has already resulted. So now we come on to question number 55, and in question number 55 is, an otherwise healthy 2-day-old infant girl is brought to have small inflammatory pustules on the torso and extremities, but sparing the palms and the soles. On further inquiry, the mother informs that these lesions were not present on the first day after birth, but appeared on day 2. A smear of the pustule contents is prepared. What would you expect to see on the smear? So the correct answer is, question number of 55 is option number D, that is eosinophils. So the diagnosis of this image was that of erythema toxicum, which is often seen to be an exaggerated allergic, it is an exaggerated immune response to certain unknown allergens. And the clue in this question was that it never appears on day 1. So here the question itself, it was mentioned that it was not there when the child was born. So it never appears on day 1, and if a smear is made from these pustules, it will be rich in eosinophils. So this was a condition of erythema toxicum. So next we come on to question number 56. And question number 56 was, infective endocarditis is not seen in. And the correct answer is option number A, and that is ASD. So we know that infective endocarditis can result in lesions which are at high pressure, or if there is a stenotic lesion, or if there is an orifice through which there is flow of blood through high pressure. So whenever it is a high pressure lesion, infective endocarditis is more common. And because we know that in ASD, both the atria are almost at the same pressures, there is very minimal pressure gradient, and hence infective endocarditis is least commonly seen in patients with ASD. So we come on to the next question, and the question is, in infants and children, severe anemia may be associated with all except, and the correct answer is option number D, that is elevated ST segments. So in a child who has anemia, it is seen that it can have some cardiac involvement as well. So when the HB reaches around 7 grams per deciliter, there would be an increase in the cardiac output. When the HB falls further down to around 3 to 4 grams per deciliter, then there may be significant cardiac enlargement that can be noticed. Apart from that, there is often tachycardia, which we all know that in a child with anemia, you will find that the heart rate is quite rapid. Along with that, the pulse pressure would be widened. And in ECG also, certain changes may be seen, and important amongst these are depressed ST segment, and flat T waves. So these are the important ECG findings that can be seen in children with anemia. So now we come on to question number 58. And question number 58 is, autosomal recessive polycystic kidney disease is common in children, and the primary organs involved are, and the correct answer is option number B, that is kidney and liver. So we know that in a patient with autosomal recessive polycystic kidney disease, there are multiple cysts that may be seen in the kidneys, and along with that there may be evidence of hepatic fibrosis as well, and hence affecting the liver also along with the kidneys. So there may be evidence of hepatic fibrosis also in patients with autosomal recessive polycystic kidney disease. So next we come on to question number 59, and question number 59 was, regarding bronchiolitis, following is false, and the correct answer is option number D, that is seen in children between 1 to 3 years of age. So we know that bronchiolitis is a common condition that can be seen from 6 months till 2 years of age commonly, and the most common organism that is responsible for causing bronchiolitis is respiratory syncytial virus. Apart from that, other viruses are also known to cause bronchiolitis, and they include the paramyxovirus and metapneumovirus. The child may present with tachypnea, tachycardia, and there may be a history of preceding viral prodrome manifesting in the form of low-grade fever, cough, and coryza. On auscultating the chest, wheeze may be present, which may be both monophonic and polyphonic. And in such children, it is important to maintain oxygenation by giving them supplemental oxygen, and antibiotics have no role in the treatment or management of bronchiolitis. Why? Because it is a viral infection. Like I have mentioned, that RSV, or the respiratory syncytial virus, is the most common organism that causes bronchiolitis. It is not a bacterial infection, hence antibiotics have no role to play in case of bronchiolitis. So next we come on to question number 60, and question number 60 was, focal lobar pneumonia is characteristic of which microorganism? And the correct answer is option number A, that is strep pneumoniae. So strep pneumoniae is responsible for causing lobar pneumonia, and that is mainly because it causes a lot of local edema that aids in the proliferation of organisms, and hence aids in the spread to the surrounding area. While group A Streptococcus results in more diffuse infection, and Staph aureus results in confluent bronchopneumonia along with formation of pneumatoceles, empyema, and sometimes even bronchopleural fistula. So different organisms have different manifestations. So we see that lobar, if there is lobar pneumonia, we suspect strep pneumoniae, and if there is diffuse infection, we suspect group A Streptococcus, and if a patient presents with bronchopneumonia along with certain complications like pneumatoceles, empyema, or bronchopleural fistula, we need to suspect that Staph aureus is the causative organism of this condition. Next we come to question number 61, and question number 61 is, gold standard investigation for bronchiectasis is, and the correct answer is option number A, that is thin section HRCT. So bronchiectasis is a condition where there is irreversible dilatation of the airways, and a HRCT is the investigation of choice which helps you to make a diagnosis of bronchiectasis. So doing a HRCT will help you to tell the location of the lesion, whether it is diffuse or localized in a single lobe, and along with that if there are any mediastinal lesions as well. Along with that, it will also tell you whether the bronchiectasis is cylindrical. So if there is a cylindrical bronchiectasis, there may be tram lines that may be seen or signet ring appearance. And in case of varicose type of bronchiectasis, there may be bronchi with beaded contour and in case of a cystic bronchiectasis, there may be cysts present in strings and clusters. So these kind of So we see that the HRCT is the investigation of choice for diagnosing bronchiectasis, and it not only tells us about the location of the lesions, whether they are localized or diffuse, and they also tell us whether there are any mediastinal lesions as well. So a HRCT will be able to tell us whether it's a cylindrical bronchiectasis, and in cylindrical bronchiectasis we may see tram lines or a signet ring appearance, while in varicose type of a bronchiectasis the bronchi may show a beaded contour. In case of cystic bronchiectasis, cysts may be seen in strings or clusters. So these are the important points that you should know about HRCT. So now we come on to question number 62. And question number 62 was, what is the role of lumbar puncture in children with febrile seizures? So the correct answer to this question is option number D. That is, it is recommended in children less than 1 year with the first episode of febrile seizure. So option number D is recommended in children less than 1 year with first episode of febrile seizure. So what do we need to know about febrile seizures? So febrile seizures are common in the age group of 6 months to 5 years, and there can be either simple or complex, and usually in children who already have a family history of epilepsy, they are at higher risk of developing epilepsy later in life. So this point is important when we have to counsel the parents. Otherwise it is not associated with any long-term consequences. Then we should know that the drug that is used for prophylaxis in febrile seizure, that is clobazam, which is given intermittently, or this is also known as intermittent prophylaxis for febrile seizures. But with regard to this question, LP is indicated or a lumbar puncture is recommended if the first episode in less than 1 year of age. So if a child who is less than 1 year of age who presents with fever and a seizure, then he warrants a lumbar puncture to rule out meningitis. And this is because meningeal signs of meningitis are not very easily elicitable in children less than 1 year of age. Hence, this recommendation of a LP in case of first episode of febrile seizure in children less than 1 year of age. Next we come on to question number 63. So question number 63 was, a 2-week-old female child presents with virilization and hypertension with decreased renin levels and with hypokalemia. The diagnosis is, and the correct answer is option number So this was question number 64. So we will first do question number 63. So question number 63 was, a 2-week-old female infant has a head circumference of 40 centimeters, that is more than 98%, with a large and a tense fontanelle and downward deviation of eyes. She has been vomiting her formula and she is irritable. Common cause of her symptoms include all except. So the correct answer to this question is option number B. That is brain tumor. So what are the clues in this question? So we see that the first is that it is a 2-week-old child. 2-week-old child who is coming with a large head, who is vomiting, and there is downward deviation of eyes. So all these are signs of raised ICT. So raised intracranial tension is causing these symptoms in a 2-week-old child. And the options that were given to you were intraventricular hemorrhage, meningitis and aqueductal stenosis. So we know that all these signs of raised ICT in a 2-week-old child can result because of any of these reasons that are mentioned except brain tumor, because brain tumor is not common in a 2-week-old child. So hence this is the correct answer to question number 63. So now we come on to question number 64. Question number 64 was, a 5-year-old female child presents with virilization and hypertension with decreased renin levels and with hypokalemia. The diagnosis is, and the correct answer to this question is option number A, that is 11-beta hydroxylase deficiency. So these are the various enzymes that cause congenital adrenal hyperplasia, and so how the manifestation differs with regard to deficiency of different enzymes. So we see that 11-beta hydroxylase deficiency (3-beta hydroxy steroid dehydrogenase deficiency and 21-alpha hydroxylase deficiency, all are associated with virilization in females. However, 3-beta hydroxy steroid dehydrogenase can also be associated with male pseudo hermaphroditism. while hypertension is associated with only 11 beta hydroxylase deficiency and 17 alpha hydroxylase deficiency. They both cause hypertension, but 11 alpha hydroxylase deficiency causes male pseudo hermaphroditism and not female pseudo hermaphroditism. Hence, the correct answer is 11 beta hydroxylase deficiency. So now we come on to question number 65, and question number 65 is true statement regarding hydranencephaly is, and the correct answer is option number D, that is brain stem is intact in hydranencephaly. So what is hydranencephaly? So hydranencephaly is a relatively rare cause of large head or hydrocephalus where the two large cerebral hemispheres are missing and are replaced by two large membranous sacs. So the cerebral hemispheres are replaced by membranous sacs. But the midbrain and brainstem are intact. The cause of hydranencephaly is largely unknown, but it has been believed that it may result due to occlusion of bilateral internal carotid arteries. So we see that in hydranencephaly, the cerebellar hemispheres are replaced by membranous sacs, but the midbrain and brainstem remains intact, and the cause may be due to bilateral occlusion of the internal carotid arteries. So coming on to question number 66. Question number 66 was, which of the following is not a constituent of meconium? And the correct answer is D, bacterial flora. So the meconium is composed of following components: water, which is almost 80%, comprises 80% of the meconium. Apart from that, lanugo, vernix, desquamated epithelial cells, and intestinal secretions like bile acids and bile pigments. However, because at this time the gut is sterile, bacterial flora is not a component of meconium. So now we come on to question number 67. And question number 67 again was an image-based question, and you were asked which of the following curves denotes lymphoidal growth curve, and the correct answer is option number A, that is the curve A is showing lymphoidal growth. So lymphoidal growth is shown by curve A. And why is it so? We will just see. So in this question, if you see clearly, there is an increase in the growth And you see by around 10 years of age, after that there is a deacceleration. So this is what the normal lymphoidal growth is like. There is an increase in the growth in the childhood years, following that there is a deacceleration. So this is about the lymphoidal growth. And what about the other curves? If you see clearly, you see the curve B. You see in curve B, the maximum growth has occurred up till around 2 years of age, and after that there is a plateau. So graph B in this question denotes the brain growth. And what about graph C? If you see in graph C, there is growth that is seen. First there is an increase, then there is a plateau, and then there is an increase again after 10 years of age. And this curve C represents somatic growth. And what does the curve D denotes? The curve D denotes that of gonadal growth. So you see there is hardly any growth up till 11 or 12 years of age, and after that there is a spurt. So this graph D represents gonadal growth. So these are the different curves of figure that was shown to you in question number 68. A child is admitted in pediatric intensive care unit with shock. A central venous catheter or CVP is placed. His cardiac output is increased. Systemic vascular resistance is decreased. Mean arterial pressure is normal and wedge pressure is decreased. And the CVP is decreased. The most likely diagnosis is, and the correct answer is question number 68. The option is option number D, that is early septic shock. I will now briefly tell you the differentiating features, the hemodynamic variables which differentiate the different types of shock. So which are the different types of shock? You have hypovolemic shock, cardiogenic shock. In this case we will discuss the systolic failure or systolic shock, obstructive shock, distributive, and septic shock. Now many books also discuss distributive and septic shock together because they say septic shock is also a part of, or just it behaves similar to distributive shock, but there are few differences. So we will be discussing them a little in differently. So, and the parameters which help you to differentiate between these different types of shock are, the important ones are cardiac output, the systemic vascular resistance, the mean arterial pressure, the capillary wedge pressure, pulmonary capillary wedge pressure, and the central venous pressure. The parameters that are given to you in this question. So in hypovolemic shock, the cardiac output is reduced, and that is because the preload is less. And as a compensatory mechanism to maintain the blood pressure, the systemic vascular resistance is increased. The mean arterial pressure may be either normal or may be reduced. The capillary wedge pressure is reduced significantly, and the central venous pressure is also reduced significantly. While in cardiogenic shock, in this case systolic, because there is a pump failure, the cardiac output is significantly reduced, while the systemic vascular resistance is significantly increased. The mean arterial pressure is either normal or reduced. The capillary wedge pressure is increased because of back pressure, and the CVP is also increased. In obstructive shock, the cardiac output is reduced. The systemic vascular resistance is increased. The mean arterial pressure again either is normal or is reduced. the capillary wedge pressure is again increased and the venous pressure is also increased. While in distributive shock, the cardiac output is increased, the systemic vascular resistance is reduced, the mean arterial pressure is again either normal or reduced, the pulmonary capillary pressure is either normal or reduced, and the CVP is either normal or reduced depending upon the severity. Now, septic shock can be either classified as early or late. The early one sometimes is also called as warm shock, and the late is also sometimes called cold shock. Now, in early septic shock, which is also known as the warm shock, there is a significant increase of cardiac output, and that is why the peripheries appear to be warm, and that is why it is also called as warm shock. The systemic vascular resistance is reduced, the mean arterial pressure is reduced or decreased, and the pulmonary capillary pressure is reduced, while the CVP is also reduced. While in late septic shock or the cold shock, the cardiac output decreases, the systemic vascular resistance also decreases, the mean arterial pressure also decreases, the pulmonary capillary pressure increases, and the central venous pressure is either increased or, so you see it is the early septic shock where the pulmonary capillary wedge pressure is reduced. In rest all, except hypovolemic shock where it is significantly reduced, the capillary wedge pressure is increased or is normal as in the case of distributive shock. So the option D is the correct answer. And you should also know early septic shock in some books is also referred to as warm shock. So next we come on to question number 69. And question number 69 was, a 6-year-old boy, known case of post-streptococcal glomerular nephritis, is having hematuria and proteinuria and a low C3 level since the last 2 months after the onset of disease. What will be your next line of management? And the correct answer to this question is option number B, that is to do renal biopsy. Usually the microscopic hematuria or hematuria that happens after PSGN, usually it recovers within the 2 months. So if microscopic hematuria is persistent, then it is an indication to do a renal biopsy to rule other diagnoses such as SLE or chronic glomerulonephritis. So if microscopic hematuria, if persists for more than 2 months, and it should also be considered in cases where there is a nephrotic range proteinuria in PSGN, in the absence of evidence of previous streptococcal infection, absence of evidence of previous streptococcal infection, and if there are normal C3 levels. So these are the indications when you should consider a renal biopsy in a case of PSGN. So next we come on to question number 70. And question number 70 was, renal biopsy should be considered in cases of all of the following except. And the answer to this question is post-streptococcal glomerulonephritis. So option number A, PSGN, is the answer to this question, and why it is so, I will just tell you. So you see the other options in this question are onset of nephrotic syndrome in a child less than 1 year, which is again a indication for doing biopsy in a case of nephrotic syndrome, presence of acute renal failure in nephritic syndrome, and post-streptococcal glomerular nephritis with normal complement levels. So like I have already discussed in the previous question, in case of PSGN, if there is absence of evidence of previous streptococcal infection and if there are normal complement levels in a patient where you are suspecting PSGN, it is an indication of doing renal biopsy. While in cases of nephrotic syndrome, if the onset is less than 1 year, if there is sustained hypertension, if there is no response, or if proteinuria persists beyond 4 weeks after starting steroids, persists even after 4 weeks of starting corticosteroids, and if you are contemplating starting, if cyclosporin or tacrolimus have to be started, as immunosuppressive agents. Then in such cases, a renal biopsy is warranted in cases of nephrotic syndrome. So this was about question number 70.